So, I'm going to talk to you about Radius-Maumenee Syndrome. And Radius-Maumenee is the eponym for idiopathic episcleral venous pressure engorgement, and it can look like a carotid cavernous fistula. So, basically, they have the typical corkscrew type vessels, and it'll look like carotid cavernous fistula. However, as opposed to a CCF, where on MRI and CT you will see a dilated superior ophthalmic vein, in the Radius-Maumenee you might see nothing, or you might just see small veins engorged. Of course, the only way to know for sure is to do a catheter angiogram, which is the gold standard for dural fistula, including carotid cavernous fistula. And one of the reasons you might do a catheter angiogram is, even though the carotid cavernous fistula is usually benign and is defined anatomically by the Barrow classification, high flow, direct tear in the ICA being an A, and then B, C, and D being low flow fistulas that are that can cause ophthalmoplegia but don't kill you, and are the internal, the external, or both carotid artery supply. The Barrow doesn't tell us about the thing we're really worried about in any kind of dural arterial fistula, which is cortical venous drainage. So that is a different classification scheme, and we use the Conyard classification. So in a Conyard 1, you have anterograde flow. So even though you have a fistula, it's still going the right direction. In a 2A, you might have retrograde flow, but you do not have the thing we're worried about, which is cortical venous drainage. In a 2B, the cortical venous drainage, and as you know, the main risk for cortical venous drainage is a venous hypertension and a venous hemorrhage or a stroke. And so anything above 2B is going to be bad and probably is going to need treatment. These two are benign. So once you start getting to Conyard 3, 4, and 5, these are more dangerous, including the 2A plus 2B, so they're not exclusive. And once you start having venous hypertension and venous ectasia, and for the 5, spinal involvement, these are going to require treatment, because that venous ectasia is the sign that we're having dilation and increased venous side pressure. So if you do all the workup, and of course it can't be like episcleritis, scleritis, the usual causes of red eye. You have glaucoma, and in the Goldman equation, as you know, it's a combination of the fluid production divided by the outflow plus the episcleral venous pressure. And so when you have Radius-Maumenee, you have idiopathic episcleral venous pressure that raises intraocular pressure as defined by the Goldman equation. And you have to make sure it's not a CC fistula, with imaging for the dilated superior ophthalmic vein, catheter angiogram to rule out fistula, but especially 2B or not 2B on the Conyard. And once all this is done, if it's negative, then you're back to the idiopathic eponymic description, Radius-Maumenee.